معمول. بس مش طالع عندنا. وش النظام؟ كيف صار وضعك؟
يعني الأمور أحسن.
منيح. وعلى
السلام عليكم ورحمة الله. الله يعطيكم العافية جميعا. دكتور يوسف، الله يعطيك العافية سيدي. هي المحاضرين معنا موجودين، إذا بتحب تتفضل حضرتك.
السلام عليكم. جاهزين إن شاء الله؟
إن شاء الله.
جاهزين إن شاء الله سيدي.
دكتور باسم يعطيك العافية حبيبي.
مساء الخير جميعا، يعطيكم العافية. طبعا لنا الشرف إنه يعني نبلش بأول ويبينار مشترك بين الجامعة الأردنية وبين الخدمات الطبية الملكية. إن شاء الله يكون بداية خير. زي ما أنتم عارفين الموضوع اليوم عن الفيمر فراكتشرز. حكون في 4 محاضرين، 2 من الجامعة الأردنية واثنين من الخدمات الطبية. إن شاء الله بيعطونا معلومات ممتازة، هي موجهة للمقيمين طبعا بكل المستويات، سواء كانت جونيورز أو سينيورز. ناخذ تيبس اند تريكس. نبلش بالهيبس وننتقل إلى الفيمر شافت وديستال فيمر. على بركة الله نبلش، وإن شاء الله تكون هاي يعني بداية لسلسلة من الويبينارز مستقبلا لعم فائدة على الجميع. بالتوفيق ويعطيكم العافية.
إن شاء الله سيدي، شكرا كثير لكم ونتشرف بوجودنا معكم. وأكيد إن شاء الله يعني ناخذ من خبراتكم ونتعاون إن شاء الله في الأيام القادمة. وأكيد هاي يعني فاتحة خير إن شاء الله بيننا وبينكم إن شاء الله. نبلش إن شاء الله محاضرات.
تمام، أتوقع أن أول محاضرة تكون دكتور تغلب بده يحكي لنا عن hip fractures in general كأبروتش وبرنسبلز. تفضل تغلب إذا أنت جاهز.
يعطيكم العافية وتغلب، بس في عندنا مشكلة صغيرة بالصوت، هاي بظبطها وإن شاء الله بنبلش معنا.
دكتور تغلب، في مشكلة عندك شيء بتحب أساعدك بشيء على زوم؟ في عندك أي شيء؟
مرحبا، هيك الصوت واضح؟
دكتور تغلب، نعم صحيح.
خلاص تمام، معلش هو كانت مشكلة هلا زبطت تخيل.
اتس رايت. في أنا أعطيت لك أكسس إذا بتحب تعمل شير سكرين.
تمام، هي شير انتير سكرين. بحكي لي مش مفعل الشير سكرين، مش عارف ليه.
طيب أنا عندي ألاود شير سكرين عندك، بعدين نختار سكرين. إيش بعطي؟
اوكي، هي مش عارف بينت عندكم هيك.
أوكي إكسلنت، يلا ممتاز. تفضل دكتور تغلب.
يعطيكم العافية، كيف حالكم؟ أنا اسمي تغلب العوض، أنا مقيم عظام مستشفى الجامعة الأردنية سنة رابعة. اليوم إن شاء الله راح نحكي عن hip fractures from initial presentation to prognosis. طبعا بشرفنا كثير يعني هذا الميتنج. إن شاء الله يعني هو موضوع كبير to cover in 15 minutes. We will talk about introduction, overview, presentation. We will talk a bit about management, although there's another full lecture about management. We will touch on complication, prognosis, and we will يعني touch on some AOS guidelines. So approximately 14.2 million hip fractures were estimated globally in 2019, marking a 92% increase since 1990. This number is expected to double by 2050. يعني we expect to reach almost 30 million hip fractures every year. So this number is on the rise, and it's a major burden on healthcare systems. So what are hip fractures? The AOS clinical guidelines define hip fractures or geriatric hip fractures as fractures to the proximal femur in elderly individuals, typically resulting from low energy mechanism such as a fall from standing height, and are commonly associated with osteoporosis. So it's a bit weird to start to talk about mortality, but this is such an important topic to talk about mortality first. So across elderly hip fractures populations, the 30-day mortality ranges from 5 to 14%, depending on the cohort and care quality. About 20 to 22% one-year mortality following surgical repair. It is documented that it may reach as high as 84% with non-operative treatment, and this number reaches about 95% at 2 years without surgery. So the etiology of hip fractures are, as we all know, divided in two areas: the low versus high energy cause or etiology, which is usually related to the elderly versus young adults. So what are the risk factors for hip fractures? This is the simplest I could find to categorize the risk factors for hip fractures. There is the intrinsic risk factors related to age, sex, osteoporosis, sarcopenia, and frailty. The extrinsic factors are related to fall, sedative medications such as beta blockers, oral hypoglycemic agents as such. Poor lighting and home hazards such as مثلا الكاربتس أو الأشياء اللي ممكن تعقل فيها المرضى في البيت. Some comorbidities increase the risk for hip fractures, including dementia, history of strokes, diabetes, and Parkinson. Patients with diabetes mellitus were found to have 15% more, are 15% more likely to have hip fractures than non-diabetics. There are also other risk factors, including smoking, alcohol use, and malnutrition. So what are the hip fractures? Basically, they are classified into head fractures, femur neck fractures, intertrochanteric fractures, and subtrochanteric fractures. So there are many classifications, as we all know. We will touch on the most important ones. So regarding the femur neck, we have, regarding the proximal femur, we have intercapsular versus extracapsular. We have the Garding classification for the femur neck fracture, and we have the stable versus unstable for the intertrochanteric fractures. So the intracapsular, basically anything within the joint capsule. This includes the head, the subcapital area, the transcervical area, and the basicervical area. Otherwise, it is all extracapsular hip fractures. This is important. We will talk about it in the management section, inshallah. So the intracapsular, the results for these fractures are determined by biology. So they are liable for osteonecrosis, AVN. We can have non-union in these fractures, and they are susceptible for late arthritis. While the extracapsular outcome is determined by mechanics. So basically, we have varus malformation, malunion, and medialization of the femur shaft. The second classification is, I think we all familiar with, is the Garding classification. So it's basically predicts the risk of AVN in femur neck intracapsular fractures. So the stage 1 is incomplete fracture, stage 2 is complete without displacement, partial displacement for stage 3, and fully displaced for stage 4. As we progress from stage 1 to 4, the AVN risk progresses to almost 90%. So the third classification is reserved for the intertrochanteric fractures. We have the stable versus unstable fractures. So the stable fractures include the intact posterior medial cortex that will resist medial compressive loads once reduced, while the unstable one basically are the posterior medial comminution, the reverse obliquity, transtrochanteric fractures, and subtrochanteric extension. There is also something that is radiological, which is the lateral wall thickness. Basically, it is 3 centimeters distal to the innominate tubercle of the greater trochanter, The thickness should be more than 20 millimeters. If it is less, it is considered unstable fracture. So this is a textbook example for stable versus unstable intertrochanteric fracture, as we said earlier. The one on the left represents a stable fracture, and the one on the right is an unstable intertrochanteric fracture. So how do these patients present? So basically, they are elderly who have a fall from a low standing height or a standing height, which is a low energy trauma, or a young adult who has high energy trauma, such as road traffic accident or a fall from high elevation. On examination, there is refusal or inability to bear weight. There is shortened external rotated lower limb. There is occasionally groin tenderness, especially in femur neck fracture and hip fracture, pain on any movement of the lower limb. So how do we approach these patients? These patients صراحة حساسين يعني. We have to approach them as wholly as possible. So we start as always with history and physical examination. This point I marked it in bold. It's overlooked most of the times. We forget to give these patients analgesia. It is something that is overlooked a lot. It's important to give analgesia to these patients. Most of them are in severe pain. There are imaging. We'll talk about them in a bit. We have to do chest X-ray, especially for anesthesia purposes. Laboratory workup, which includes CBC, basic laboratory workup. ABGs and ECGs are almost always mandatory, especially for the comorbidities that the patients present with. Foley's catheter is administered, as these patients cannot move and cannot go to the bathroom. And most of all, and most importantly, these patients cannot go home and they have to be admitted. So inpatient management, how do we approach this patient as inpatient? Something that is overlooked in Jordan, actually, there is no true multidisciplinary team care for these patients. We have to involve medical care, anesthesia care, ortho care, and we have to have special nursing staff that is well capable to deal with these patients. Analgesia, as I said earlier, is overlooked, and we have sorry, في حدا حكى شيء؟ Okay. So analgesia, blood transfusion as needed, wound care post-op, pressure area care, thromboprophylaxis, nutrition, and early rehabilitation. So imaging, X-rays, CT, and MRI. X-rays include pelvis X-ray and femur X-ray, CT scan for some cases, and MRI. The American Academy of Orthopedic Surgeons recommendation is moderate strength if no fracture is detected on CT or X-rays. We have this is an image for the same patient doing a CT scan. في صوت مش عارف في حدا. This is an image for a CT scan showing the same patient, a CT scan on the left and MRI on the right. As we see, the CT scan looks normal, while on the MRI we see an undisplaced Gardner 1 or maybe 2 fracture. So what is the goal? What are the goals of management? So we have to enable the patient to return to at least pre-trauma mobility as soon as possible. We have the best outcome is to early full weight bearing, and for the surgeon, technically easy treatment. So as everything in medicine, we have the non-operative management and the operative management. Starting with the non-operative. The non-operative is usually has very limited uses. So in the literature, there are some indications for non-operative management where the patient life expectancy is very short for the totally immobile patient and severe medical comorbidities or unfit for anesthesia. Some cases, the patient himself or his family won't consent for the surgery, and this is another indication to go for non-operative management. So we have a full section about operative management. We will talk about them in a separate lecture. Basically, the overall view is hemiarthroplasty or total hip arthroplasty for femur neck fractures, intramedullary nail or dynamic hip screw for extracapsular fractures. The surgery is ideally done within 48 hours. Multiple research and meta-analysis of 1997, I believe, to 2017 covered almost 32,000 patients were found to have a 12-month mortality risk decreased by almost 20% if we operate within 48 hours. So this is basically an overview of the management options for femur neck fractures or for proximal femur fractures. We have the osteosynthesis, which include fixation, the parallel implants, the sliding hip screw, which is extramedullary splint, the intramedullary splint or nail. We have the prosthesis, which include partial or total arthroplasty. So the complications are divided into two sections. We have the medical complications and the surgical complications. Something that is overlooked in these patients, about 50% of hospitalized elderly patients with hip fractures develop some sort of delirium, so this is extremely important to detect. Pneumonia, UTIs, DVT, PE, and MI are all common due to immobility, surgery, and stress response. As we said earlier, these patients are frail and usually have multiple comorbidities that go along with them, so we have to treat them as a whole. Pressure ulcers, especially for delayed patients, pressure ulcers develop within 72 hours in 20% of population if not treated properly. The surgical complications are related to the surgery itself and the type of surgery we do. Infection remains one of the top enemies of orthopedic surgeons. The second one is AVN related to the vascularity, especially if we choose fixation over arthroplasty or any other form of modality of treatment. Implant failure or non-union, especially an intertrochanteric or subtrochanteric fracture related to the mechanical stability of the fracture. Reoperation can reach as high as 10% within the first year of management. So this slide is extremely important. It talks about the prognosis of these patients. 50% never regain pre-fracture mobility. 15 to 30% become permanently dependent in activities of daily living or require some form of nursing care. Walking without aids drops significantly, particularly in those over 85 years of old. Sorry, okay. So the long-term prognosis, these patients are at increased risk of subsequent fractures, especially the other hip, high burden for cognitive decline and depression post-fracture. There is persistent decline in quality of life even at 12 months. So we'll finish off this lecture by talking a bit about the American Academy of Orthopedic Surgeons guidelines. So these guidelines were published in the 3rd of December in 2021. They replaced the old guidelines of 2014. They are targeted for the hip fractures above 55 years of old. They include about 60 pages, which are easy to read actually. They include 18 evidence-based recommendations, 16 are moderate strength, and 2 of limited strength. So we'll talk about them briefly. So basically what they did in these guidelines, they compiled almost 9,000 studies and exclude them, they did some exclusion criteria and narrowed them down to 12 high quality or moderate quality studies. So as we will talk a bit, there is a strong, moderate, and limited statement strength, and there is some evidence quality of high, moderate, and low. So when we say high, moderate, or low, the strong or high include two or more high quality studies. The moderate is one high quality or study at least. The low include two or more low quality study or one moderate quality study. they are يعني راح يكون في جنبهم نجوم strength visual موجودين على كل وحده هلا راح نحكي عنهم ان شاء الله. هدول حكينا عنهم هلا. في شغله مهمه لما نحكي strong the practice is unlikely to change. So يعني في future research will not impact these guidelines, while for the moderate, limited, and consensus the impact of future research might be unknown or less likely to change according to the strength. So the first one is preoperative traction. Preoperative traction should not routinely be used for patients with a hip fracture. This is long gone. Multiple high-quality studies suggest not doing it. It has no benefit at all. The second one is surgical timing. Within 24 to 48 hours of admission is associated with better outcomes. As we said, there is a high quality, moderate quality meta-analysis between 1997 and 2017. The sooner the better for these patients. VTE prophylaxis should be used in hip fracture. This is the strength of recommendation is strong. This is unlikely to change. So either spinal or general anesthesia is appropriate for a patient with hip fracture. There is no difference at all, actually, in hospital stay, in mortality rate, in post-op complications. The only difference was found in one moderate study suggested that the pain post-op for spinal anesthesia was better than general anesthesia. So for unstable femoral neck fractures, displaced femoral neck fractures, arthroplasty is recommended for over fixation. The rationale behind this is the risk of AVN is higher as we go to the unstable side, so the quality of evidence is high and the strength of recommendation is strong. Unipolar or bipolar hemiarthroplasty in patients with unstable displaced femoral neck fractures can be equally beneficial. This is of moderate strength. Outside Jordan, actually, there is a bit difference in the price. In Jordan, I think there is not that much difference of the price, and most يعني معظم الشركات نتعامل معاهم صراحة إنه الباي بولر هو الستاندرد صار عندهم. So for unstable femoral neck fractures, total arthroplasty versus hemiarthroplasty in properly selected patients with the unstable displaced femoral neck fractures, there may be a functional benefit to total hip arthroplasty over hemiarthroplasty. So this is يعني a two-edged sword. Basically, there is nothing wrong here and nothing right. It totally depends on the patient himself. So if the patient is mobile, has good activity, and well educated, total hip may be appropriate. But in some cases, total hip may need يعني arthroplasty surgeon or hip surgeon present. So this is completely related to the center we're working in and the patient himself. So cemented femoral stems in patient undergoing arthroplasty for femoral neck fractures, the use of cemented femoral stems is recommended. The quality is high and the strength is strong. The rationale behind this is that cemented femoral stems offer better post-op pain and lower risk of periprosthetic fractures. This was confirmed by multiple high-quality studies that the guidelines used. In patients undergoing treatment for femoral neck fractures with hip arthroplasty, evidence does not show a favored surgical approach. This is of moderate strength. So basically, do what you're comfortable with. One study suggested that a slightly higher, not by much, dislocation rate for posterior approach arthroplasties. Although this was found in only one study, other studies did not show that. Cephalomedullary device in patients with stable intertrochanteric fracture, use of either a sliding hip screw or cephalomedullary device is recommended. There is no difference between them. The strength of recommendation is strong. So for subtrochanteric or reverse oblique and the unstable intertrochanteric fracture, we should use the cephalomedullary device. This is strong in both these recommendations. A blood transfusion of no higher than 8 grams per deciliter is suggested for asymptomatic postoperative hip fracture patients. You have to take this with a grain of salt because, as we said earlier, about 50% of patients with delirium do not report symptoms accurately. So almost always have a low threshold for transfusion. Multimodal analgesia incorporating preoperative nerve block is recommended to treat pain after hip fractures. This is strong, as we all know. One thing is on the rise, which is fascia iliaca block. Fascia iliaca block is extremely important and was found to have extremely good outcomes in patients with hip fractures. Tranexamic acid should be administered to reduce blood loss and blood transfusion in patients with hip fractures. So in Jordan University Hospital, about, I don't know, 3 or 4 years ago, tranexamic acid use became the standard of care here for hip fractures pre-op. Interdisciplinary care programs should be used in the care of hip fractures patients to decrease complications and improve outcome. This one is self-explanatory. These patients have multiple comorbidities. They have extremely difficult physiology to deal with. So we have to be very careful when we deal with them. Of course, interdisciplinary care programs must be applied or implemented well in these patients. So we reached the end of this lecture. So the take-home messages: hip fractures are a global health concern with high mortality and morbidity. Early surgical intervention improves survival and reduces complications. Multidisciplinary care is essential for optimal recovery and outcome. Many patients experience long-term disability and loss of independence. Keep yourself updated on the latest guidelines as it is now an evolving topic. Thank you.
جزيلا تغلب، يعطيك العافية. أتوقع هلا بنروح على النكست توك، ويمكن نخلي الأسئلة والملاحظات للآخر عشان ما نطول بعد إذن الدكتور يوسف طبعا.
أكيد سيدي، تفضلوا.
محمود أنت جاهز؟ The next talk will be about the management tips and tricks in hip fractures, mainly intertrochanteric fractures, presented by Dr. محمود القواسمي, our Chief Resident at Jordan University Hospital. محمود تفضل.
يلا بس أعمل شير. يعطيكم العافية. مرحبا، يعطيكم العافية. أتوقع إنه السكرين هلا شيرد مع الكل. أنا محمود القواسمي، سينيور ريزيدنت بالجامعة الأردنية. Our talk will be focus on the critical steps and tricks in the surgical management of intertrochanteric fracture, a very common fracture that we deal with on a daily basis. The outline of our lecture will start with the preoperative planning, positioning of the patient in the OR, reduction of the fracture, and tips and tricks on the surgical technique. Starting with the preoperative planning, as any other surgery in our field, we should plan our surgery before entering the OR. The first point to plan preoperatively is the choice of implant. DHS versus intramedullary nail has been a very hot topic since long time. There is an extensive literature about this point, whether to choose intramedullary nail or DHS, and based on what you should take your decision. Nowadays, there is a huge shift towards the intramedullary nail due to the improved biomechanical engineering and the improved stability of this implant. Now, the choice of our implant will depend on the stability of fracture. To assess our stability of fracture, we should check on 4 main points. The first one is whether our fracture is a reverse oblique fracture. That means that our fracture extends from the lesser trochanteric area into the lateral cortex instead of going to the greater trochanteric area. The other point is whether it has a posterior medial comminution or not. As we all know, the posterior medial cortex of the proximal femur is the thickest cortex in our body, and it bears the most of our weight at this area. So comminution in this area means that our fracture is unstable and requires nailing instead of applying DHS. To assess posterior medial comminution, we usually look at the lesser trochanteric chunk, whether it is a big chunk, whether it is comminuted or not, and then we determine if it has comminution or not. Or instead, we can use CT scans to assess the posterior medial comminution in a more accurate way. The third point is the lateral wall thickness. This is an important point to determine the use of DHS or not. We go into the innominate tubercle, we go distally 3 centimeters, and then we measure the cortex at 135 degrees toward the head, and we measure the thickness of this cortex. If this cortex thickness is less than 20 or 21 millimeter, that means that DHS cannot be applied and it cannot have good stability of the fracture. Instead, we use intramedullary nails. And the final point, whether we have a subtrochanteric extension of the fracture, that means that it is an unstable fracture and we should go toward intramedullary nailing. Now, after we choose our implant with the DHS or intramedullary nail, we then should determine what are the characteristics of our implant. As we all know, there is a neck shaft angle, an angle between the shaft and the neck, and this should be determined before going into the OR, because implants like nails and DHS come in different neck shaft angles, and we should choose the right neck shaft angle for each patient. Now, the patient, we should look at the contralateral and normal side and determine the neck shaft angle and to check whether it is available or not. The second one is whether to choose a long or short intramedullary nail. That depends on the stability, the extension of this fracture towards the shaft and the subtrochanteric area, and the cause of the fracture, whether it is a fragility fracture or it may be a pathological fracture. And in these cases, we go to long intramedullary nailing. The last point is the implant diameter. We should approximately measure the diameter of the medullary canal and to check with the medical rep and the company whether the diameter, the appropriate diameter for the patient is available or not. The second point, in the preoperative planning, is to anticipate the probability of the need of open reduction, and if there is a need of open reduction, we should check that our reduction tools and kits are available in the OR. Now, after planning, we will bring our patient into the OR. The first important point, like any other orthopedic surgery, is the patient positioning. Positioning usually for intratrochanteric fracture is supine on a traction table. We should put the patient in the correct position and check our position with the C-arm to make our life easier in the OR. Now, few tips about the position. The first one is that we should put the post in the perineal area and to make sure that the genitalia are not under pressure. And then we should bring the torso into 10 or 15 degrees into the contralateral side to facilitate the nail entry and to open this area at the greater trochanteric area so the iliac bone is not on our way. The second point, after putting the patient in the correct position, we should bring the C-arm before draping to check if good AP, lateral, and axial views can be taken. The first view is the AP view. We should take a picture and an image showing the hip with the hip joint, the peritrochanteric area, and the shaft in a single image without any metals from the table. The other view is the lateral view. The lateral view, as we can see here, is a true lateral at the patient, and we should assess the antiversion of the femur, which is around 15 degrees. And finally, the other view is the axial view. We're taking the C-arm and to 20 degrees or 30 degrees external rotation, and the corrective view is checked when the head and neck and the shaft are all in the same line. So all these views should be taken, checking that there are no obstacles in the way of the C-arm, and we can view and assess our reduction. Now, after checking the position, we do our reduction. The reduction is the most important and most critical step in our surgery, and it should be done before draping and before incision. The reduction, a quick maneuver and tips like it's to start by doing gross traction. Then we do extreme external rotation so we can disimpact the segments, and then go into internal rotation to reduce the segments until we check our reduction based on a few points. The first one is by looking into the cortical lines. The continuity of the medial cortical line on the AP view and the continuity of the anterior cortical line on the lateral view is our target. We should check if there is any overlapping fragments which suggest shortening and of our reduction, and we should do more traction. If there is any translation or sagging, and we should deal with it. And if there is any angulation, especially the varus angulation. So these are intra-op X-rays for acceptable reduction. As you can see on the AP view, we have a continuous medial cortical line. We don't have any varus angulation by looking at the tip of the greater trochanter and drawing at a horizontal line, and it should pass toward the center of the head. Finally, to check for the rotation, we should look at the cortical thickness, and it should be matched between the proximal and the distal segments. While looking at the lateral view, we should check firstly at the antevergent, that is around 15 degrees. There is continuous anterior cortical line, and again about looking at the cortical thickness to check for any malrotation. Now, the varus angulation, which is the most common malreduction in intertrochanteric fractures, we should check it by drawing, as we have said, a transverse line passing from the tip of the greater trochanter, and it should pass into the center of the head. As we can see on this picture, we have a perfect reduction, perfect cortical thickness, and continuous medial cortical line, but still we have varus angulation. In these cases, we always should check on the contralateral side to check if the patient have a physiological Savara. In these cases, we should use implants with less degrees of neck shaft angle to match this coxavara and to proceed with it without any changes on our reduction. Now, the nightmare of intertrochanteric fracture is the posterior translation or the posterior sagging. It's a very common, and it's more common in unstable fractures and comminuted fractures. We have a few tips to overcome this sagging and this translation. Firstly, by applying direct pressure by the assistant on the inferior distal segment, and push it upwards towards the proximal segment, or the other maneuver is to use a Human on the proximal segment to push it downwards so it can reach the shaft, the side of the shaft. We can use also both of them at the same time, but it's always easy. Should remember that we should keep our Human and our manual force all the way from inserting the nail and inserting the blade. We should not lose our reduction while applying our implant. As we always know, that nail is not a reduction tool, and it's only for fixation. So it should not be used as a reduction tool. Now, the second critical point after reduction is, we all know, is the entry point. The correct entry point will make our surgery easier and will avoid the possible complications of malpositioned blade and malpositioned nail. The site of our entry is the tip of the greater trochanter. At the C-arm, we should always see our owl. It's perfectly to be on the top, on the tip of the greater trochanter. and we should palpate it, whether it is anterior or posterior by our hand. When we check our correct position, we apply our guide wire. If it was too lateral, it will result in varus reduction to allow the blade to enter the head, and or on the contrary, the blade will go forcefully into a superior blade position, which is also not accepted. On the axial view, anterior or posterior, if it was too posterior, the entry, we may have anterior cortical perforation, especially in the elderly patient in intertrochanteric fracture who have already excessive anterior femoral bowing. Now, there is a difficulty that we can always face while applying our reamer and applying our nail, is that the fracture site is very near to our entry point, and when we apply our reamer, it will distract these two segments and result in a deformity called fish mouth deformity. Now, in order to counteract this deformity, we apply direct pressure on the lateral aspect of the femur to compress these two sides while applying our reamer and opening our canal for the nail. Then, after opening the canal, we advance the nail. We always take too many C-arm imaging while advancing our nail in order to check whether the wire should be positioned in the correct position or not. And we always put our wire and we see that it's superior, then we remove it and go advance the nail more for the correct position. A very useful tip that we sometimes use, we look at the level of the lesser trochanter, and usually the entry point for the wire, which is this area, should be at the same level of the lesser trochanter. At these sites, usually the guide wire will be in a central position on the AP view, which makes our life easier, and we use less C-arm images. Now, the correct position, it's either central on the AP and central on the lateral, or slightly inferior in the AP and central on the lateral view. Otherwise, superior are not accepted because it may result in cut through and failure of the reduction, and anterior or posterior are never accepted. Lastly, till where we should advance our blade or screw. Usually, our aim is the subchondral bone, which has the best purchase with the blade or the screw, and usually around 5 to 7 millimeters away from the joint line. We have reached the finish of our lecture. Our take-home messages: we should always prepare before our surgery, even if it is a routine surgery like these surgeries. Reduction is the most important step of intertrochanteric fracture fixation. Do not use the nail as a reduction tool, and correct entry point is a critical step to avoid complications and to make your life easier. Thank you so much. وسوري إذا طولنا عليكم. إذا حدا عنده أي سؤال ممكن نشوفه آخر الويبينار إن شاء الله. يعطيكم العافية.
يعطيك العافية دكتور. And thank you for your lecture. Now we have Dr. Malik Abu Hazim, and he's in the 5th year. He's talking about femoral shaft fracture, management options and surgical tips. تفضل دكتور مالك.
تمام سيدي، الله يعطيك العافية. هسه بس نعمل شير. الله يعطيكم العافية جميعا. أنا الدكتور مالك أبو هزيم، مقيم جراحة عظام الخدمات الطبية، مركز تأهيل الملكي، سنة 5. Our talk today will be on adult femoral shaft fractures, pitfalls, controversies, and best practice. This patient is a 43-year-old male patient, medically free, was transferred to our emergency as a victim of RTA. He was a driver, intubated, with bilateral lung contusions with left side hemothorax. As we see, the patient has bilateral comminuted femur shaft fracture. What do you think we should do for this patient? Does he need X-fix as a damage control or acute definitive fixation with IM nail? And if he needs X-fix first, when should we do the definitive surgery? We will see what happened at the end of this seminar. By the end of this presentation, we aim to differentiate the optimal timing of femoral shaft fracture fixation, evaluate the advantages and limitations of different patient position during IM nailing, apply reliable techniques for reduction assessment, select the appropriate IM nail fixation strategy, analyze the decision to ream or not to ream in femoral intramedullary nailing with chest trauma. Let's start with simple but very important questions. When should we definitely fix a femoral shaft fractures? Is early IM nailing always the safest option, or can it be harmful in the physiologically unstable polytrauma patient? Does early fixation reduce pulmonary complication and ICU stay, or does it increase the risk of acute respiratory distress syndrome and multi-organ failure in patients with chest trauma? To answer this, we will now look at the most recent clinical evidence comparing early intramedullary nailing versus stage fixation in polytrauma patient. This study published in the Journal of Orthopedic Trauma in 2022 by Opé and colleagues. It's a retrospective observational cohort study. It specifically examined the relationship between delay to femoral shaft fracture fixation and in-hospital morbidity and mortality. Among the 108,000 unilateral femur shaft fracture, the impact of timing of surgical fixation was determined by assessing its effect on first mortality rate, length of stay, length of time on ventilator, and the presence of any post-operative in-hospital complication. They conclude that patients who underwent fixation more than 48 hours after presentation were at increased risk for increased morbidity and mortality. The title of this study, Two Big Bones, One Big Decision. This study was published in Elsevier Injury Journal in August 2024. This study assessed the impact of early, which is less than 24 hours, versus delayed definitive fixation for polytrauma patients with bilateral femur shaft fractures on clinical outcome, especially focusing on concomitant fixation of bilateral femur versus staged repair. Upon analysis, they found that every 24-hour delay to definitive fixation increased the odds of developing complication by 1.05, increased the odds of post-op length of stay by 10 hours, and total hospital length of stay by 27 hours. So they conclude that early definitive fixation of bilateral femur shaft fracture reduce complication and ICU stay compared with delayed or stage fixation. When it's not applicable or not feasible, early stage fixation is preferable to complete delay. This is one of the biggest debatable topic between surgeons, reamed versus unreamed intramedullary nailing. As we all know, reamed nailing benefits to our patients is better for union outcome compared to unreamed technique. On the other hand, unreamed nailing benefits less blood loss and shorter surgical time. So what does the evidence say overall? The study was published in the Medicine Baltimore Journal on July 2016. It's a meta-analysis of prospective randomized controlled trial, around 8 randomized controlled trials involving more than 1,000 patients. This study showed that reamed intramedullary nailing of femoral shaft fracture was associated with shorter time to fracture union, lower rate of non-union and reoperation, and there were no significant difference between reamed and unreamed intramedullary nailing in terms of implant failure, mortality, acute respiratory distress syndrome, or blood loss. But in severely injured patients with chest trauma, surgeons often debate to go for damage control with X-fix first versus early definitive nailing. This study was published in European Journal of Trauma and Emergency Surgery in the last July 2025. This is a retrospective cohort study. Clinical endpoints include the mortality, the ICU care, length of stay, and total hospital length of stay, multi-organ failure, and blood transfusion rate. This study shows comparable mortality and organ failure between IM nail and X-fix in chest-injured polytrauma patient. Thus, they challenge the standard belief that X-fix always protects severely injured lung. Now, as we plan to nail the patient, positioning is the first clinical step in femoral shaft nailing. The choice affects reduction quality, operative time, radiation, exposure, and potential complications. There are many positions. Each surgeon is familiar with one or multiple of them. Supine on traction table, or supine on radiolucent table with manual traction, or lateral decubitus position. As we all know, supine on traction table is most commonly used, provide excellent length control and stable traction, but there is a risk of soft tissue or perennial injury and requires careful monitoring. While supine on radiolucent table with manual traction is useful if traction table is unavailable, but requires skilled assistant to maintain reduction. The lateral decubitus position may be technically challenging for imaging and requires surgeon comfort. Do patient position really matter? Let's see what the literature tells us about operative outcome, complications, and malalignment across these positions. And while all three positions are used in practice, the study mainly compared two at time. This is the FLIP study. It's a multi-center prospective cluster randomized crossover trial that was published in Journal of Orthopedic Trauma in September 2025. They found that the odds of this study compare between supine with traction table and the lateral position. They found that the odds of femoral malrotation of more than 15 degree were 2.6 times higher in the supine with fracture table. This another study is a prospective randomized single-blind study, was published in Elsevier Injury Journal in 2024. The aim of this study was to compare the radiological and clinical result of femoral shaft fracture operated in the lateral position with those operated in supine position. Patients who were operated in the lateral position have the shorter preparation time, surgical time, and number of fluoroscopy doses. The difference in the amount of bleeding and need for open reduction were not statistically significant, neither the difference in femoral joint range of motion and rotational evaluation. There was no significant difference in terms of complication between those two groups, so they conclude that lateral position is safe and effective, comparable to traction table. After the discussion about the patient position, the next key decision is the type of nail and entry point. There are multiple type of nails regarding the entry point, antegrade nail versus retrograde nail. The antegrade nail either trochanteric versus piriformis. So those choices affect both the technical ease of surgery and patient outcome. As we all know, the antegrade nail, it's indicated in most femoral shaft fracture, especially proximal and mid shaft. It has the advantage to preserve knee joint, but there is a risk of abductor injury. The retrograde nail distal femoral is indicated in distal femoral shaft fractures, polytrauma, associated ipsilateral femoral neck. The advantage is easier for distal shaft fracture, but there is risk of pain, arthrotomy, and injury to the cartilage and chronic knee pain. Regarding the antegrade nail, there is trochanteric versus piriformis entry, which is better. So let us look at the recent evidence comparing those nail types and entry point to understand when and why surgeons choose one over the other. This is a systemic review and meta-analysis comparing antegrade versus retrograde nailing for femoral shaft fracture. It was published in Archive of Bone and Joint Surgery Journal in 2024. They found that higher rates of hip pain and heterotopic ossification was observed with antegrade nailing. However, a higher rate of knee pain was appreciated in retrograde nailing. But there were no significant difference in remaining analyzed outcomes such as operative time, reoperation rate, or other complication. This regarding the antegrade nail trochanteric versus piriformis. This study was published in Injury Journal. It's a retrospective comparative cohort study that compared piriformis entry nail with the retrograde and trochanteric entry nail. Controlling for possible covariable, the analysis yield a significantly lower decrease in femoral version for trochanteric entry nail than piriformis or retrograde nail. And regarding the rate of revision surgery, trochanteric entry nail also had a significantly lower revision rate, even when controlling for all other variables. This study you see right now is one of the first clinical studies to quantify gait and muscle structural changes after trochanteric entry nailing using gait analysis and ultrasonography. This was published in 2025 in Journal of Orthopedic Surgery and Research. It's a retrospective observational study included patients who underwent trochanteric entry nail. At 1 year post-op, they evaluate the patient regarding the bilateral gluteus medius muscle thickness by ultrasound and plantar pressure distribution and gate parameters were performed use gate analysis system. Although those patients achieve good bone union, there were medium effect deficit in gait parameter and muscle morphology. So this suggests surgical entry throughout the greater trunk may have subclinical effects on the gluteus medius, which can be persist long term if not addressed with rehab. Now, once the patient is positioned and the nail type chosen, the next step is accurate fracture reduction. The aim of our reduction is to restore length alignment and rotation. So proper reduction is essential to prevent the malunion, rotational deformity, and length discrepancy. Started with length assessment, there is intraoperative technique by fluoroscopic contralateral ruler method, and post-op CT scan measurement is the most reliable means of accurate leg length assessment after fixation. As fluoroscopic contralateral ruler method may be inaccurate and unreliable. This is a cadaveric study that was done on 8 cadavers. Approximately 5 centimeters of bone was removed from the left femur shaft. Then 7 orthopedic surgeon residents and 2 attendings measured the length of the intact contralateral femur using a ruler under fluoroscopy. The ruler was then applied to the fractured femur with manual traction applied until femoral length matched the measured length of the contralateral femur, and the resulting gap in the fractured femur was compared with length of bone that had been resected. So despite poor reliability, the fluoroscopic ruler resulted in a mean leg length discrepancy of 8 plus minus 5.8 millimeter in this cadaveric study. Regarding the rotational assessment, there is a clinical and fluoroscopic method. Clinically, by comparison with the contralateral limb, hip and knee rotation, which is the basic pre-op and intra-op. Pre-op fluoroscopic, the fluoroscopic method, we can use 2 methods. Preoperative fluoroscopic imaging centered for the lesser trunk. We match the lesser trunk shape from the uninjured leg with the operated leg. So matching the lesser trochanteric shape is one of the techniques. The other one is the cortices thickness. When the rotational alignment is correct, both the lesser trochanteric profile will match the opposite side and the cortical thickness should match. The final one is the alignment. We can use multiple technique. One of this is the bovie cord, which is the cautery cord. It used to assess the malalignment. The bovie cord is stretched from the center of femoral head to the center of the ankle and held in place with the clamps. An AP image of the knee is then taken. If the mechanical axis has been properly restored, the cord should pass directly through or slightly medial to the center of the knee. Now, after all of this, let's get back to our patient from the first slide. And here is how things turned out. This patient underwent bilateral X-fix, which was the definitive surgery, no nail. And here are the follow-up X-rays after 10 months. And on the left side of the slide is the standing X-ray scanogram, which show acceptable mechanical axis somehow. Patient is doing well right now. Good range of motion in both knees. He has full weight bearing, no pain. We took the permission from our patient to attach this video in our seminar. He can do bending of both knees. He can do kneeling. He has good range of motion. Take home message, choose position and timing wisely, assess reduction carefully, select fixation thoughtfully, and remember, fix the patient, then the bone. Thank you.
Thank you, Dr. Malik. And now we will talk about distal femur fracture, advanced fixation and technical insights. Dr. Muhannad Al-Armouti, and he's in the 5th year in our residence in the 5th year. تفضل دكتور مهند.
يعطيك العافية سيدي.
هلا بيك، تفضل.
Allah يعطيكم ألف عافية. Our talk today will be about the distal femur fractures. السلايد واضحة؟ Hello?
واضحة، تفضل.
واضحة تمام، تفضل.
Okay, our talk today will be about the distal femur fractures. So we'll start about this case from the injury journal about 64-year-old obese female on anti-osteoporotic treatment for 2 years. So what we have, a closed distal femur fracture after a ground. What they did for him, they used the locked system to treat this fracture. But on the follow-up, what happened? This what happened. So we look what caused this type of failure. Is it due to patient factor or due to the surgical technique have been used? This what will go through our presentation. Our learning objectives to describe the surgical anatomy of the distal femur and its relevance to fixation, define the treatment aims in the distal femur fracture management, explain reduction techniques, including indirect reduction principles, discuss available implants and the evolution of distal femur fracture fixation. So, like many fractures, it's distributed in the bimodal distributions, high energy trauma in young patients, and fragility pattern in the elder patients. What about the anatomy? The story is not just about two condyle. It has a complex trapezoidal shape. So you have to know very well about this anatomy, because if you missed it, you may end up with a disaster. It's not easy all the time because you have to address the failure that may happen. The distal femur shape, it's wider posteriorly than anteriorly, and you have to look the intercondylar fossa about its anatomy. So looking to the deforming forces, we have the gastrocnemius muscles that may lead to posterior angulation of this fragment. So you have to keep the traction while you're doing your reduction, not on extension, as that will increase and propagate the deformity. We may do the flexion by using a post or to put behind the knee, anything that will help to decrease the deformity. Okay, do we consider all a distal femur fracture are the same? In the fact, it's not a single entity. Many systems try to classify the distal femur fracture. AO classification, one of the best classification, as it's described the extra-articular, partial articular, and complete articular. How that will help us to address the treatment and will guide our mode of fixations. If you go to the investigations, this is the normal X-ray, the proper X-ray. It's very important to know how to do it. The AP, the lateral views. If you look to the left side, the AP views, how patella are centrally located, the fibula overlapped 1/3 with the tibia, and what looks in the lateral, superimposed both condyle. If you identify the proper X-ray, you can look to this one. What do you see here? We see a double density sign. So if we took the lateral view, we can see this of fractures. So the coronal fracture sometimes can be seen in the sagittal view. So do we need to do CT scan for all distal femur fracture? In the fact, you have to lower the threshold for CT scan to demonstrate the intra-articular involvement, to see if there is an associated Hoffa fracture, as the incidence is 38% incidence of Hoffa fracture, and which is missed 31 نسبة كبيرة, lateral side more than the medial side. So don't hesitate to do the CT scan to identify the injury and to plan your surgery. Other investigations, we may do the angiography. This is indicated when diminished the pulses distally or if associated with a knee dislocation. Let's go to the treatment. Either we have non-operative or operative. In fact, the non-operative treatment, we reserve this type of treatment for the non-ambulatory patients, المرضى اللي low demands أو بيكون في عندهم high degree of surgery or anesthesia risk. In fact, always we try to go for the operative treatment. And let's remember here what our principles. Looking back to the AO principles of fracture management, anatomical reduction, stable fixation, preservation of blood supply, and early mobilization. How do we start our treatment? We have the external fixator. It's like look to 1983. This study is telling the indication and limitations as a staged therapy. Sometimes we do if the patient is unstable or soft tissue status not permitting you to the surgery. we have to go for external fixator. The best strategy is external fixator as a stage therapy, then early conversion to internal fixation. But do we consider this treatment as a definitive treatment? In the fact, it's not, because it's far away the mechanical axis from the fixator. The bending force is very high, and the instability associated with the pin micromotion may lead to poor sagittal alignment, and that may end up with the stiff knee. But look here, what happened in this article. They describe a Salter-Harris type 2 fracture for pediatric age group, and what they use for this patient is an circular external fixator, and the result was very nice. So some authors, they agreed that close reduction using percutaneous pins and screws for Salter-Harris type 1 and 2 is the treatment of choice. Our classic treatment for this type of fractures, we have the open reduction internal fixation through various approaches. We have the lateral approach, anterolateral, medial, lateral parapatellar, medial parapatellar, and always we try to go for MIPO approach, less invasive surgeries, with some modification of Swiss specular approach, modified anterior lateral. If you want to look more anterior, the benefit of this approach will help you to reduce the lateral soft tissue stripping. So you may decide your surgical plan according to your experience, the fracture geometry, and according to which surgical exposure you need. Okay, after we finish with after we choose our surgical approach, what will help us during the traction? We have many options, but the aim is one, is indirect reduction. We try to do indirect reduction until we obtain the proper alignment. We have the femoral distractor to restore the length. We may put زي مثل ما حكينا البوست اللي تحت الني to relax the gastrocnemius وبترجع لنا الفيمورال بو. And sometimes you may need, or you may use the traction table, but be sure that you have the port tools that available to do the flexion of the knee that may not disturb your reduction. Other useful trick, we may put like a chance, نحط chance wire loop over the pins ونحاول نرجع posterior pending if the reduction was not easy. So our goals بنحاول بالعادة to do the goal. Our goals is to do the indirect reduction to maximum preserve the soft tissue, obtain length, alignment, and rotation. هسه ديفلوبمنت تبع الامبلانتس نطلع من البليد بليت انت باست الكوندايلر سكروز كيف كانت. Then nowadays what we are using the distal femoral nail والlocked LCB system is more used. So this evolution nowadays, even a less invasive stabilizing system, we use it nowadays. Fixed device بنستخدمه احنا بالاوستيوبروتيك community fractures. It succeeds very well to use in these fractures, but you need to do the correct technique, use the plate length that's proper to fix the fracture, and good working length. We start our plan. We have the fracture, we have to do the plan, downgrade the fracture. كيف يعني؟ بكون عندك interarticular fracture, you have to fix the interarticular component on the first. بنحط السكروز فري سكروز زي ما احنا شايفين. بعدين ممكن we add our plate after that, but be sure the position of the plate. إذا كانت plate beyond the Blumenstadt line ممكن يصير عندنا screw penetration. اتأكد proximally upstairs, you have to look upstairs whenever you apply your plate to look where it's seated to prevent the recipe of failure. Short plate إذا كان reduction not optimal, or the plate off proximally, length of the screws, all these factors should be addressed. من الشغلات اللي ممكن تصير معنا جلف كلب ديفورميتي. طبعا اذا بنطلع على هاي الديفورميتي بتصير lateralizing shifting. شو الاشي بسويها؟ happened when a plate placed too posteriorly distally, or you tried to get satisfaction by bringing the plate to the bone. So this should be prevented by elevating the diaphyseal cortex مثل ما احنا شايفين هون. يعني it's a locked system, so you can use it easily by this technique. This is for regarding the plate. Now, other modality of treatment is intramedullary nailing of distal femur. Intramedullary nailing, this is one of the good options if you have the comminutions. It's good for to be used for smaller incision to preserve soft tissue. weight sharing device. This will help if you have the fracture at least 6 centimeters from the joint line. Some issues with using the nail إذا كان distal fracture أو في عندك comminution كثير ممكن ما تقدر تستخدم النيل. We have many options to use in this fractures. The issues of fixation, sometimes you face an osteoporotic patient, pre-prosthetic fractures, comminution. These need to be addressed different than others. So look here, retrograde nailing used to augment the fixation with plate. So used plate, the plate and nail, augmented fixation. When we need to do the medial fixation. If you have medial wall defect more than 2 centimeters, if you have a medial hoof, if you have a non-union, it's recommended you can use allograft or you can put a medial plate, double plate fixation. But the problem that you may expect in the upcoming generations of follow-up of these patients, they will have a non-union due to stiffness. It's an option, but to predict the T-cup morphology, double plate will act as like a load sharing device. If you prevent the, if you look to this picture, how the shearing forces, they may lead to failure. Other option of treatment is putting a plate on plate. Look here, proximal plate, distal plate. You can connect them with each other as a one construct. And the result, the patient was very happy for this fixation. Other specialty of this fracture, we have the Hoffa fracture. Albert Hoffa, a German surgeon, described this fracture shearing forces in the posterior condyle. The mechanism of action with axial load, knee flexed more than 90 degrees, will lead to this type of a fracture. What makes it special? In fact, the treatment of this type of a fracture is not easy. This paper in the Psychot journal, they published about radiological classification, Bagaria classification. This classification tried to use the cut on the axial CT scan, the size of the fragment, if it's more than 2 centimeters, less than 2 centimeters. This will guide you how to put your screw either from posterior to anterior or anterior to posterior, and will help you to choose it's enough to use a screws or we need to add a buttress plate. If you want to go more deep, you can read about this study. So the rationale of nail plate fixation. This is the debate about using a plate, using a nail, or using both of them. As we know, the lateral plate is a load-bearing device, receive the full load, and the intramedullary nailing is a load-sharing device. So if you combine both of them, what will happen? This is a superior stability. But the drawbacks of looking of these 6 studies, all of them, they are telling you that the nail plate is a better fixation for union and for the mobility, ambulation. But issue is that the problem with using nail plate, we need more prospective studies. We need to address the cost of this method of fixation, and sometimes it's need the highly demand experience of the surgeon. If you look to this screw, what kind of this screw is used? This is a partial threaded screws, compress the bone, far cortical looking screw. This is the new concept of fixation in distal femur fracture. This is far cortical screws, control the motion to stimulate a callus. So the biomechanic advantage of this screw, this is giving you a flexible fixation, better load distribution, progressive construct, stiffness. And if you look here how it works, you can see distally it's looked fixed to the distal cortex, and proximal they did over drilling and may give some toggling to promote callus formation. But keep in mind, the far cortical looking screws helps only when working length is adequate. So we looking back to our case that we present in the beginning. This is about the failure happened. The fixation used here, it's a nail plate. Okay. Our take-home messages: understanding the osseous anatomy of the distal femur is critical. Indirect reduction technique should account for forces from the gastrocnemius muscle. Fixation implants should have some form of angular stability. Both plates and nails have wide indication with reliable results when used correctly. الله يعطيكم ألف عافية.
يعطيك العافية دكتور مهند.
يعطيك العافية.
في حد عنده أي سؤال للأطباء الزملاء المحاضرين؟ ما في ولا أي سؤال؟
دكتور يوسف يعطيكم العافية.
على سيدي. طبعا الدكتور أيمن مصطفى كان بيحضر المحاضرات من البداية. الدكتور أيمن مصطفى رئيس دائرة جراحة العظام عندنا في الخدمات الطبية، ونتشرف بوجوده معنا. أتوقع حابب يعطي مداخلة بسيطة بعد إذنكم. تفضل سيدي.
تسلم سيدي، الله يعطيكم ألف عافية جميعا، ويعطيك العافية دكتور يوسف على الخطوة والبادرة الطيبة واللي رجعتني بالذكريات لما كنت مقيم وكنا نروح على الجامعة، وبمدرج الجامعة نعمل محاضرات مشتركة، ونروح على مستشفى الأردن نعمل معهم محاضرات، ويجونا على مركز فرح مدرج الأمير حمزة. كانت لايف طبعا، بس هلا التكنولوجي يعني قربت البعيد وسهلت الأمور. فصحيح جهدك مشكور جدا أنت والشباب باللجنة العلمية، وأنا سعيد كمان إنه زملائنا بالجامعة الأردنية يكونوا معنا ونتعلم منهم ويتعلموا منا ونسمع من بعض ونتواصل مع بعض. لأنه يعني إحنا كلنا قطاعات صحية في البلد بنكمل بعض وبنفيد بعض إن شاء الله. يعني مبادرة جميلة جدا إنك تجمع بين الجامعة والخدمات الطبية، وإن شاء الله في المستقبل نشوف لقاءات أوسع مع بقية القطاعات والمستشفيات. وسعيد جدا بمستوى العالي للمحاضرات اللي سمعته من الشباب ما شاء الله عليهم، سواء زملائنا المقيمين بالجامعة أو بالخدمات. ويعني أعطونا شغلات updated ونيولي published papers، وهيك لازم يكون الحكي. يعني اوكي بنبدأ بالبيسك وبعدين نرتقي بالكلام للlatest recommendations. وانا شخصيا والله تعلمت واستفدت. وصراحة بستغرب من بعض الزملاء المقيمين اللي حضروا أول محاضرة أو محاضرتين وانسحبوا. يعني كنت عم بشوف مين دخل مين طلع. الإقبال كويس والعدد ممتاز، لكن نرجو إنه في المرات الجاية يكون الكل موجود. ومرة ثانية جهدك مشكور دكتور يوسف، أبدعت أنت وأعضاء اللجنة العلمية معك طبعا جميعا بدون ما أنسى حدا منهم. وفرصة سعيدة إنه التقينا بإخواننا بالجامعة الأردنية. شكرا.
شكرا لك. والدكتور باسم حداد شكرا كثير له، تعاون معنا بطريقة جد ممتازة كثير، ويعني ما بقدر أوصف قديش تعب معنا. يعني إن شاء الله في الأيام القادمة راح نتعاون أكثر وأكثر، وإن شاء الله نحاول نعمل هيك محاضرات وجاهية إن شاء الله، سواء نروح على الجامعة الأردنية أو هم يتفضلوا عنا. يعني بالعكس هذا شرف لنا سيدي. دكتور باسم تحب تحكي أي شيء؟
أكيد شكرا لك دكتور يوسف، أكيد دكتور أيمن، يعني هو أعزاء علينا. وأنا صراحة مبسوط جدا إنه صار في تعاون مشترك. يعني هاي الخطة يمكن كان لازم من زمان تنعمل. يعني احنا يمكن بالجامعة عندنا يعني نوع مختلف عن المرضى اللي بيجوا على الخدمات الطبية. ممكن أنواع المرضى برضه غير بتكون بوزارة الصحة والقطاع الخاص إلى آخره. فدائما التعاون وتبادل الخبرات شيء مهم جدا، وبساعد الجميع انه يتقدم بتقديم الخدمه للمريض. وانا شخصيا يعني يمكن صار لي بعالج هيب فراكتشرز وفيميل فراكتشرز يعني 20 سنه تقريبا، ولا شك اني تعلمت اليوم. فما في اي حدا كبير على العلم، بالعكس هذا شيء كثير كويس. دائما بنراجع العلم، محاضرات صراحه على مستوى عالي، احسن ما توقعت، وهذا شيء كثير ممتاز ومميز. وإن شاء الله هذه تكون يعني بادئ خير لتعاون مستقبلي بمواضيع أخرى، سواء كانت وجاهي أو أونلاين. ودائما نستفيد من بعض. شكرا جزيلا لكم. ودكتور يوسف يعني هذا واجبي إنه أنا يعني أشترك معكم وأبذل قصارى جهدي عشان تنجح العملية التعليمية لجميع زملائنا المقيمين اللي هنا راح يحملوا الراية في المستقبل.
الله يحميك.
شكرا جزيلا للجميع.
الله يحميك. شكرا
أهلا
لك.
وسهلا.
شكرا كثير.
العفو.
يعطيكم ألف عافية وشكرا لوجودكم معنا. وبالنهاية بنشكركم جميعا لحضور المحاضرات هاي، وإن شاء الله تكونوا استفدتوا منها زي ما نحن استفدنا منها إن شاء الله. شكرا كتير ويعطيكم ألف عافية. السلام عليكم.